Bismillahirrahmanirrahim. Now we are going to start the autonomic pharmacology. So it's very important regarding the pharmacology because the upcoming system, especially the CV system, the CNS system, the your respiratory system, so they rely over the autonomic pharmacology. So you have to uh, very good basic understanding of the autonomic. Then you can easily jump into the CNS or CVS or the respiratory. So upcoming session. So starting with it's a just introduction lecture where we just going to revise some the physiology anatomical concept and then add some pharmacology concept. So our learning objective will be the first we try to look at the anatomical and functional distribution of nervous system, compare and contrast the autonomic nervous system versus the somatic nervous system, and compare contrast the parasympathetic versus the sympathetic nervous system, and the cholinergic system and the adrenergic system. So, and we also look at the neurotransmitter and their synthesis, which is the you say acetylcholine and the norepinephrine. So they're because they're mostly used in the autonomic system. So we love to discuss their synthesis as well as the pharmacology associated with that, and the location and the types and location and the mechanism of action of the receptor for the parasympathetic as well as the sympathetic. So you may have heard of the muscarinic, nicotinic, alpha, beta receptor. We are talking about that. So starting with the basic, the nervous system, you know better, they have two divisions: central nervous system and the peripheral nervous system. In the peripheral, in the central, brain and spinal cord, while in the peripheral nerves and ganglia are included. So peripheral have two parts. One is the autonomic, and other is the somatic. Autonomic means, as the name represents, it's involuntary, which is not in our control, while the somatic is the voluntary, which is under our control. So in the autonomic, there are two subdivisions. One is the parasympathetic, other is the sympathetic. Parasympathetic, simply parasympathetic peace, in the condition of, you can say, peace, rest, and digest. So it's a condition, rest and digest. So mean your easier way, you can say your whole body is resting, especially the digestion. Your GAT mechanism is hyperactive. Okay, while in the sympathetic, which is a fight and flight condition. So the responses in the sympathetic and the parasympathetic is easier to just to imagine, not to memorize. So just imagine you are running away from a dog. What will happen to your eyes? Your eye become dilated. You are accommodating for the far vision. Okay, so let's come to the heart. What will happen to heart? Heart activity goes up. Your respiration rate goes up. Your GAT, no, it's go down because it's a rest and digest for the parasympathetic. We are looking at the sympathetic because you are running away from dog. What about the urination? No, I am running away from the dog. So how I can think regarding the urination? Means your these symptoms are going to be closed. So and if you look at the emission is associated with the sympathetic, while the your pointing, or you can say parasympathetic, penis become erection is associated with the parasympathetic, while the emission is associated with the sympathetic. So these are simple. If you look at the parasympathetic opposite, your eye become again they of course less converge. So concavity go down and mean they are going to be accumulate for the near vision, and your heart activity goes back to normal, and your respiration go back to normal. And what about the GAT? Rest and digest. GAT goes up. Urination, of course, the parasympathetic sphincter will open. So these are simple concepts, not difficult to understand. So here is just a table you can easily study although you are familiar from your physiology and anatomy. So same thing in the eye, their contraction, where in the salivary gland, regarding the sweat gland, they are always, whether it's a sympathetic or the parasympathetic, both have the secretion, but the difference is in the thickness. Okay, so in thick and viscous in the your sympathetic, while the watery in the parasympathetic. So we have discussed all of them just and regarding the blood pressure, of course, in the you are pumping more and more blood, more energy. So in the sympathetic, your blood vessels are going to be dilated mostly. So let's see the somatic nervous system formation and the structure and the your which is associated with the mostly skeletal muscle, while the autonomic nervous system, which is associated with the cardiac and the smooth muscle and the glands. So there, if you look at their structure anatomical, how their formation occur. So in the CNS, there is a nucleus and there is a receptor away from the CNS. So the nerve goes there. So single nerve which is the cholinergic type, mean they are releasing the acetylcholine. So single fiber. While if you look at the autonomic formation, so from the CNS nucleus to the receptor, they there are two fiber are going to be used. So this is the ganglia in between the receptor and the CNS. So first fiber come from the CNS, go to the ganglia, and the second fiber go from the ganglia to the receptor. So the fiber before the ganglia, preganglionic, after the ganglion is the postganglionic. Okay, so preganglionic fiber and the postganglionic fiber. So, and other important thing you can see the first fiber, whether you are looking at somatic or whether you are looking at the autonomic, the first the fiber release the acetylcholine, mean they are cholinergic type, and the postganglionic may be the norepinephrine or the acetylcholine, depending upon the sympathetic or parasympathetic. So we can go forward. So cholinergic neuron we have discussed, then the adrenergic. Cholinergic are those which release synthesize the acetylcholine, simple. And your parasympathetic nervous system, they are also known as the cholinergic because they love to secrete the synthesize the acetylcholine. Receptor for the parasympathetic, they are two, nicotinic and the muscarinic. In the muscarinic, although there are five subtypes, while in the nicotinic, NM and N, we are going to look at in the next slide. So remember in the PNS, first in the peripheral nervous system, always as I mentioned, always cholinergic, whether it's a somatic, whether it's a parasympathetic, whether it's a sympathetic. So first neuron is always a cholinergic type. If you look at the adrenergic, so of course they release the norepinephrine. Sympathetic nervous system, they are usually called as the adrenergic system, but there are few exceptions you must need to know because they are really tested. So there are few exceptions: the sweat gland and the erector pili muscle. These are the cholinergic type. Okay, in the sweat gland and in the erector pili muscle. So they are cholinergic type, mean this here the neurotransmitter is the acetylcholine. Okay, receptor for the adrenergic is the alpha and beta. You just remember for the cholinergic is the nicotinic, while for the muscarinic is the nicotinic and muscarinic for the cholinergic system. Mean acetylcholine bind with either the nicotinic receptor or either with the muscarinic, while the norepinephrine bind with the alpha and beta type receptor. Okay, so just a summary point for the parasympathetic, as I mentioned, you know better, they are coming from parasympathetic, come from the cranial nerve 3, 7, 9, 10, and the S2 to S4 segment of your the vertebra. So parasympathetic outflow, preganglionic fiber release the acetylcholine, come to the ganglion, which is N, nicotinic N type. Okay, and the release of acetylcholine, mean postganglionic is acetylcholine, preganglionic is also acetylcholine, mean they are both cholinergic type. So parasympathetic autonomic nervous system cholinergic type, and your receptor is particular muscarinic for the various organ, cardiac, smooth muscle, and gland. So in these both fiber are the cholinergic type. Let's look at the sympathetic. So T1 to L2, your segment thoracic and L2 level, the outflow come from the vertebra T1 to L2. You know better. So preganglionic acetylcholine, ganglion, postganglionic norepinephrine. So this is a sympathetic adrenergic system. So various organ, cardiac, smooth muscle, their receptor is alpha and beta. Okay. So if you this is preganglion, this is ganglia, this is a postganglion. One important difference in the parasympathetic and the sympathetic. If you look, the preganglionic fiber in the sympathetic is the short, while the postganglionic is the long. While if compare with the parasympathetic, the preganglionic is the longer one, while the postganglionic is the short. So this is simple your anatomy. So in the exceptional case, you know better, the preganglionic acetylcholine, postganglionic acetylcholine. It's a sympathetic. The example is for the your sweat gland and erector pili muscle. So keep this concept clear. So and other you need to know from the TA to L1, your preganglionic acetylcholine goes to the adrenal medulla. Okay, so you do better. The adrenal medulla release the catecholamines, norepinephrine and the epinephrine. So here is no postganglionic. So because if you look at the embryology of adrenal medulla, so they have neurological nervous system the origin. So that's why they release hormone, not synthesize the neurotransmitter. So their secretion is the epinephrine and the norepinephrine via the blood. Okay, you know, but because it's a part of your endocrine system. Endocrine always release the secretion into the blood. Okay, so this is also, although the preganglionic is the sympathetic, while there is no postganglionic, here is actually secretion come into the blood. Okay, so alpha, beta 1, beta 2. Okay, so this is the basic concept you can see. So you can see the first fiber is always acetylcholine. Okay, I think one is somatic. So there is single fiber unit and the secretion is the acetylcholine. These are the lower motor neuron and go to skeletal muscle. So you can observe the first is always acetylcholine, 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 acetylcholine. While in the parastem both are acetylcholine, while in the sympathetic mostly norepinephrine, but there is two exceptions: sweat gland and the erector pili muscle. While in the adrenal medulla, there is no postganglionic. Actually, the secretion go via the blood. Okay. No, adrenal medulla produce epinephrine hormone, not neurotransmitter. Important thing. And the hormone produce action away from the site of production via blood. Understandable, not difficult. Neurotransmitter produce action on the innervated tissue and organ. Why this is important? Because your beta 2 receptor, they are not innervated. So there is they are not innervated. So they show only response to epinephrine, no action of the norepinephrine. Okay, this is basic concept you must need to know, because going to become challenging in the upcoming session. So norepinephrine has no effect on the beta 2 receptor, so it's never decrease the blood pressure because there is no action of the norepinephrine. So and the one other association, the dopamine system. So we also discuss with them with the autonomic. So preganglionic acetylcholine, postganglionic is the dopamine. So their receptor is the D1. Okay, so they also add the renal, coronary, and the mesenteric supply. So they increase the blood flow toward the renal, coronary, and the mesenteric. Okay, so they are coming from the midbrain, ventral tegmentum area. So the vasodilation system, it's of the blood vessel. They are not directly, they are occur by via the nitric oxide endo. Okay, so just look at the formation endothelium system. What is happening in the endothelium? The endothelium has M3 receptor and the beta 2 receptor. They both are not innervated. Okay, so normally whenever you see the vasodilation in the parasympathetic, there is no vasodilation. Why? Because they are not innervated. M3 at the endothelium, not throughout the system. In the endothelium, in endothelium of the blood vessel. Okay. So, but whenever you give, so in the blood vessel M3, beta 2 are not innervated. So agonists can reach only via blood. So via the blood they can reach out. For example, if you give the exogenous acetylcholine, so they can stimulate the M3 and cause the vasodilation. Vasodilation, how? By release of the endothelium release the nitric oxide, which cause the vasodilation. Okay, so the endogenous mean the acetylcholine, which is synthesized by the parasympathetic, they have no effect on the blood vessel, no vasodilation. Okay, similarly epinephrine has no effect. The norepinephrine has no effect on the beta 2. Why? Because they are not innervated. So but the epinephrine, which is coming from the your adrenal medulla, so they can come via the blood, they can also cause the vasodilation. Okay, so keep this concept clear. So and your bradykinin, serotonin, shear forces, so they also stimulate the endothelium and cause the release of the nitric oxide and cause the vasodilation. So three basic mechanism regarding the vasodilation of the endothelium. I think this is clear. So endogenous mean the acetylcholine which is coming from the nerves. They have no effect on the M3, no effect on the beta 2. Why? Of the norepinephrine. So only the agonist can reach via the blood. So this is, I think this is clear. So now just look at throughout how their vasodilation and vasoconstriction is going to happen. So there are three receptors: alpha 1, beta 2, M3. Three receptor: alpha 1, beta 2, M3. You know better. They are associated with the endothelium. only alpha 1 is the innervated. We are the CNS. So norepinephrine act on the alpha 1 receptor and cause the vasoconstriction. Okay. So while epinephrine can stimulate the, which is coming from the adrenal medulla, can stimulate the beta 2. Why they cannot alpha 1? Because the epinephrine is more affinity for the beta 2 as compared to the alpha 1. So they cause the release of nitric oxide and vasodilation. In the M3 acetylcholine, if you have given the exogenous, no endogenous, because they are not innervated. Okay, so exogenous can come here and stimulate the release of the nitric oxide, which cause the vasodilation. So vasodilation can be happen via the epinephrine or the exogenous acetylcholine. Okay, while the vasoconstriction, when the sympathetic activity happens, so in the norepinephrine, so there is they can cause the vasoconstriction via the alpha 1 receptor. So ANS, this is beloved concept over the, especially your step 1 exam, USMLE, FCPS, whatever you going to enter. So alpha 1, beta 2, M3 are present. Just summary, only alpha 1 is innervated, cause vasoconstriction, beta 2 stimulated by epinephrine via blood, cause vasodilation, M3 stimulated by acetylcholine via blood, cause vasodilation via the release of nitric oxide from the endothelium. Okay, cholinergic system, indirect agonists have no effect. Indirect agonists do what? They increase the endogenous acetylcholine because they are not never no effect. But if you have given the direct agonist, exogenous acetylcholine can act on the cause the vasodilation. Similarly, direct antagonists have no effect because they are not innervated. Because there is no stimulation of already the M3s. If they are stimulated, then you can inhibit them, antagonize them. So only one case is where direct antagonist can affect is the, if the direct the presence of direct agonist. For example, this acetylcholine you have already given, this is present here. Okay, so and if this acetylcholine is present, then you give the antagonist, so that can inhibit the action of this acetylcholine. So in the presence of the exogenous, or you can say direct agonist, your antagonist can work. But if this acetylcholine is absent, so means you have not given the already the exogenous, so what will happen to antagonist? Antagonist inhibit what? There is nothing. So no antagonism happen where the mean you in easier wording you can say, if the blood vessels are already vasodilated, they can cause the vasoconstriction of that blood vessel. Okay. Some other neurotransmitters, serotonin, peptide, purine, they are associated with the your GAT, but not much important here. So just to know, not autonomic nervous system, parasympathetic and the sympathetic. Almost all organs have dual innervation except blood vessel and sweat gland. So they are only innervated by the sympathetic. Okay. So you know better, there are no innervation for the parasympathetic. Parasympathetic nervous system mostly dominate throughout the body. Okay, except blood vessel and sweat gland, only sympathetic innervation. If you look at the for example heart rate, they are predominated by the parasympathetic. You look at the respiration, they are predominated by the parasympathetic until you increase the sympathetic activity. So mostly your parasympathetic activity dominate. Esterase inhibitor, which increase acetylcholine, increase the parasympathetic activity, but no effect on the blood vessel and sweat gland. We already know it's not difficult. Okay, because they are not innervated. Direct cholinergic agonist, for acetylcholine, cause the vasodilation. Direct, this is repetition. Direct cholinergic antagonist, for example, atropine, no effect on the blood vessel, no innervation, no neurotransmitter, no inhibition. In present, exogenous agonist, for example, atropine can cause the constriction of dilated blood vessel. Okay. Now we are going to look at the synthesis of two. We have discussed the acetylcholine and the norepinephrine. Let's see the acetylcholine synthesis. Acetylcholine synthesis, the presynaptic and the postsynaptic. This is presynaptic, this is postsynaptic. So whether it's a nerve muscle or whatever it is. So presynaptic, here is a transmitter which take the choline with the sodium. So choline and the sodium symbol. So they enter while the sodium balanced by the your ATP system, which throw the sodium out and the potassium in. So in this way, the sodium is balanced. So when they come with the choline, come with the sodium. Okay. So the choline bind with the acetyl CoA and form the acetylcholine. So okay, so this acetylcholine, how this synthesis by the help of choline acetyl transferase enzyme. Okay, so CAT in short we can say, and then by the transporter they are going to become storage. So they come into the storage form. Now, as the neurotransmission come, mean your depolarization happen. So there is, for example, you have sent the signal. So here the calcium channel open. So the calcium entry cause the release of acetylcholine into the your synaptic cleft. Okay, so this is a basic synthesis. And if you look at the target of the acetylcholine, the one target is the postsynaptic, the receptor, muscarinic and the nicotinic. Okay, they stimulate them. The other target is M2, which is the inhibitory feedback for the feedback inhibition. Okay, so the feedback inhibition mean they stop the release of further acetylcholine. The third way is they can be break down by the acetylcholine esterase, which break them into the choline and the acetate. Choline can be reuptaken by the same transporter. Okay, so this is means your the summary of this. So you can say the choline with the sodium come into the in the presynaptic and with the bind with the acetyl CoA by the help of choline acetyl transferase formation of acetylcholine, then they come into storage and by the depolarization, so calcium comes in and stimulate the storage vesicle and cause the release of acetylcholine. Acetylcholine has target number one, the postsynaptic receptor, and the presynaptic for the feedback inhibition, and the other is by the metabolites into choline and acetate. Choline can be reuptaken. So this is summary of that. So hemicholinum, so they inhibit this first mean you can uptake mean rate limiting step, that is here. This first step is rate limiting. So and the vasimicol is the other drug which actually inhibit the storage of the acetylcholine. Okay. So botulinum toxin, they inhibit the release of the acetylcholine because they are interrupting this vesicle binding with this membrane, and so they interrupt here, so no release of acetylcholine here. The other is acetylcholine esterase inhibitor, means they do not allow the destruction of the acetylcholine, mean the acetylcholine remain here and they are stimulated here, so mean they are agonist type, but you can say they might be a reversible or irreversible type. So agonist, but sometimes we give exogenous, so they directly stimulate the muscarinic and the nicotinic. So antagonist directly acting on this receptor. So we have direct agonist, agonist, nicotinic, and these are choline ester alkaloid or the nicotine with stimulate the nicotine. Indirect, so these are the indirect which inhibit them and cause really increase the acetylcholine level. So these are agonists, mean they are increasing the activity of acetylcholine. Well, the antagonists, they are antimuscarinic, antinicotinic, antimuscarinic atropine like thing. So we discuss them in the upcoming session. In the antinicotinic, there are two types: ganglionic blocker or the neuromuscular junction blocker. Okay, nicotine. So and in the neuromuscular junction competitive and the non-competitive subdivision. So inshallah we will discuss in the cholinergic and the system. Now let's look at the norepinephrine synthesis. So the amino acid tyrosine convert into L-dopa by the tyrosine hydroxylase in the presynaptic, and the L-dopa form the dopamine and by the decarboxylase and by the vesicular monoamine transporter. So they come into the storage. So come into this vesicle. Okay, in the vesicle, the dopamine converted into the norepinephrine by the help of beta hydroxylase enzyme. Okay, so then this norepinephrine come out by the other transporter, come into the storage for the norepinephrine. So similar mechanism by the depolarization, calcium comes in, stimulate this and cause the release of norepinephrine. So we have here is angiotensin, I think angiotensin 2, which stimulate the, you can say they increase the release of the norepinephrine. Okay, so norepinephrine target number 1 is the, of course, their postsynaptic receptor alpha and beta, and the presynaptic for the feedback inhibition by the alpha 2, and the M2, which is also associated with the your acetylcholine, but they also cause the feedback inhibition here. Okay, so for the feedback inhibition, alpha 2 and the M2. If you look at this is one target, number 2 feedback inhibition. The third is the direct reuptake of the norepinephrine. No, they are not they are not destroying by the any into any metabolite. Direct reuptake of the norepinephrine. So this is coming to the presynaptic. So one target is come into storage, but they can be destroyed here by the enzyme which is present in the mitochondria, that is monoamine oxidase. Monoamine oxidase can destroy the norepinephrine into the metabolites. Okay. So what we have studied, and the norepinephrine can go into the metabolites for norepinephrine. You can say here is 4 target. Number 1, postsynaptic. Number 2, feedback inhibitor. Number 3, reuptake, and the fourth one is the into metabolites by COMT. Okay. So direct agonist, before just recall, with the amino acid tyrosine, L-dopa to dopamine by the vesicle, this transporter come into the vesicle, then into storage, then release of by the calcium, and there is number 1 postsynaptic target, presynaptic, reuptake, COMT into the metabolites. Okay. The direct agonist, which can stimulate, here is direct agonist, so which are selective for the alpha and the non-selective type. Selective and non-selective, and non-selective means they stimulate the both alpha and beta, while the selective, for example, alpha 1, alpha 2, this drug beta 1, this drug beta 2. So these are selective type, while these are the non-selective. They stimulate both alpha 1, alpha 2. They stimulate both beta 2, beta 1, beta 2. They stimulate all three, norepinephrine, epinephrine. So these are the direct agonists. Indirect agonists do what? They are the tyrosine inhibitor, tyrosine hydroxylase inhibitor. They do what? They inhibit at this stage. Okay. And the next indirect agonist is the VMAT inhibitor. They inhibit the storage of this. So these are not the agonists. These are actually antagonists. And the releaser, these are actually some, you can say these are agonists. So pseudoephedrine and the tyramine, they increase the release of the norepinephrine releaser. Okay. And the other is the amphetamine. They do two functions. Number 1, they inhibit the reuptake, they increase the norepinephrine level here. And the other is they stimulate also the release. So amphetamine has 2 mechanisms. Number 1, inhibit the reuptake. Number 2, they increase the release. Okay. So the first 2 are the antagonists, not the agonists, because they are inhibiting the synthesis of the norepinephrine. MAO, monoamine oxidase inhibitor, they are inhibiting this, they do not allow to destroy the norepinephrine. More and more norepinephrine go for the storage, and more will be available in the at this site. Okay. So selegiline and the reserpine, so they inhibit the monoamine oxidase. Reuptake inhibitor they inhibit the reuptake here. So don't allow the reuptake, norepinephrine available at the receptor site. Okay, and COMT inhibitor, entacapone, entalgone, they inhibit the destruction of the prevent from the destruction of norepinephrine, norepinephrine will be available here. So other is the mixed agonists, they do what? They stimulate the number 1, the release, and as well as they directly stimulate the ephedrine, the look like a agonist, direct agonist. So this is a mixed agonist, direct as well as the indirect. When we say direct, they are directly associated with the receptor. Indirect they are increasing the level of the endogenous, the neurotransmitter. Okay. So antagonist, so they are non-selective alpha 1, non-selective alpha blocker, and the selective alpha blocker. Similarly, non-selective beta blocker, selective beta blocker, mixed blocker both alpha and beta, and the storage inhibitor, reserpine, and guanethidine. These are the release inhibitor. Okay. So we discuss in the upcoming. So cholinergic receptor, in the summary, we can say there are 2 types, the muscarinic and the nicotinic. In the nicotinic, we have N sub M. M mean they are at the level of the neuromuscular, and then N mean they are at the ganglia, or you can say in the your these are I think mixed. Neuromuscular is present at the skeletal muscle, while the NN is present at the ganglia level. You know better. So there is just a mistake. Okay, M1 and M2, M3. So these are the five types subtype of the muscular neck. But the first three, M1, M2, M3 are the mostly discussed in the autonomic. Okay, so the one is present CNS, ANS, well M2 is present heart, and M3 is present in the most of the other locations, smooth muscle and gland. So cholinergic, you know better, we have the muscarinic and nicotinic. So five subtype for the muscarinic, two subtype for the nicotinic. So the important thing they are in muscarinic are the G coupled, mean they are associated with the GQ system. Well, the GI associated with the M2 and the M4. One mean the 1, 3, 5. They are GQ, GI. So just remember throughout the pharmacology, M2, alpha 2, D2, mu, they are always the inhibitory GI system associated. So mostly they are associated with the feedback. Okay. So M2, alpha 2, M2, alpha 2, D2, mu, which is in the opioid. So D2 in the dopamine, M2 in the muscarinic, mean your cholinergic, the alpha 2 in the your adrenergic system. So just keep this concept clear. Nicotinic, so they are the ligand gated ion channel, sodium potassium channel. Okay. So receptor for the M1 location and their location is the CNS and the ENS, mean the in the gastric gland. So their mechanism, of course, GQ, mean they increase the calcium level. So when the calcium level increase, they do what? Increase the contraction. So release of the lot of things. So they increase the learning and memory in the CNS, and increase the acid secretion. Excuse me. Okay, so increased acid secretion means you cannot give the muscarinic agonist, especially which is stimulate the M1. So for the peptic ulcer or the G acidus, where the problem is the acid. Okay, so you can use the antagonist to treat the peptic ulcer and the GA distress. M2 location, heart, and the CNS. M2 you know better, GA, they decrease the cyclic AMP, mean they do what? They increase the heart activity. Okay, so two location, SA node, AV node. In the SA node they decrease the heart rate, while the AV node they decrease the conduction velocity. So decrease in heart rate mean what? Chronotropic, negative chronotropic, and decrease in the conduction, negative dromotropy. Okay, so they are not present in the myocardium. Just remember, don't confuse with the sympathetic, which is present as well as the SA node, AV node, and the myocardium. So in the upcoming slide you will see. CNS they cause the tremor. So caution in the AV block, because in the if you given the AV block where you see the normally ECG PR segment is elevated. So because they decrease the heart rate and the conduction velocity, so you it's contraindicated in the AV block patient. Okay, so you patient may die. Now M3, most of the other location, just imagine, so in the heart M2, in the CNS and the ENS the M1, the other location M3. You see the smooth muscle, eye, iris people, whatever, ciliary muscle, blood vessel, glands, GET, bladder, bronchi, liver, M3. Okay, so their mechanism is GQ, mean they increase the calcium level. So as the calcium level increase, means smooth muscle cause what? Contraction. Eye contraction cause of meiosis, and the contraction accommodation for the parasympathetic nerve region. Okay, blood vessel, you know better. So for the nerve region, so if you for example they can be cause the sacroplegia, mean blood vision for the far vision problem. So if you have given the agonist for the muscarinic, so they can cause the sacroplegia, which is the blood vision problem. Okay, so acetylcholine esterase inhibitor are ineffective, while they are actually increasing the acetylcholine, but the M3 is not innervated. Okay, so you know better. They cause the dilation via the endo from the endothelium. Baroreceptor reflex can be happen. So whenever you reflex tachycardia, why? When the vasodilation happen, what will happen? What will happen? TPR go down, means your blood pressure go down. As the blood pressure go down, this is sensed by the baroreceptor. Baroreceptor sends signal to the brain. So by the brain reflex come, which increase the heart activity to maintain the blood pressure. So that's why baroreceptor reflex can be happen with the this dilation, vasodilation by the M3. Glands, of course, they increase. Mean whenever you are in the mechanism is the GQ, they are mostly be increasing secretion and the contraction. So they increase the secretion, whether saliva, sweat, lacrimation, bronchia. GET increase the motility, cramps may be problem. Increase the peristalsis, so they can, if the hyperactivity, diarrhea, and cramps are the problem, they can. Bladder, of course, the contraction of detrus muscle in urination. Okay, bronchoconstriction. Bronchoconstriction means they should be caution in the asthma. So if you their agonists are contained for the asthma and the COPD. In the liver, they increase the insulin, so they are useful for the glycolysis and the fatty acid synthesis. Okay, so let's look at the nicotinic and subtype N. So they are located in the ganglia and the adrenal medulla and the your CNS part. So their mechanism is the opening of sodium and potassium channel. Because the depolarization, catecholamine release 80% the epinephrine and the 20% is the norepinephrine. And in the CNS, because the excitation. And subtype M, so their location is the neuromuscular junction. Okay, so NM, the sodium potassium channel, so they cause the depolarization and the contraction of the secondary. So this chart is very important because you are throughout the pharmacology, this concept is going to be repeated most of the time. Okay, now come to the adrenergic. Adrenergic, you know better, norepinephrine, alpha, beta, alpha 2 subtype, alpha 1 and the alpha 2. Alpha 1 is the alpha 2, you know better, they are the GA, while the alpha 1 is the GQ. Okay, smooth muscle, blood vessel, so nasal eye. So these are location for the presynaptic, for the feedback purpose. Okay, they're present in the presynaptic. Beta has beta 1, beta 2, and beta 3. Three major subtype, but mostly used are the beta 1 and beta 2. Okay, so they all are the GS coupled. Okay, G protein this GS coupled. They mean they increase the cyclic AMP. This is, I think, again a mistake. So they are actually not decreasing. They increase the cyclic AMP. GI decrease, GS increase. So this is, I think, a mistake. So heart, kidney, smooth muscle, blood vessel, lungs. So we're just looking at in the. So adrenergic receptor 2 subtype alpha beta, and both are G coupled. You can say GQ for the alpha 1, GI for the alpha 2, and GS for. Important thing is the at the low dose, your beta are more sensitive than the alpha. Mean your most of the pharmacological action are coming at the low dose drug. If you are given the smaller dose, mean they stimulate the beta. But if you are given the larger dose, they stimulate the alpha most. Mean your alpha receptor is going to be predominant. So action of the alpha. Let's see the action of the alpha and the beta. Alpha 1 location, blood vessel, eye, radial muscle, GIT, kidney, urinary bladder, trigone and sphincter, vas deferens, liver. Alpha 1 GQ, you know better, blood vessel, GQ mean they cause what? Contraction, vasoconstriction, eye, contraction of radial muscle. Radial muscle are outside. So for example, if this is the circular muscle, so radial muscle are present outside. Mean when they contract, they do what? They cause the vasodilation. Okay, mydriasis. Dilation, dilation, mydriasis. So dilation of the your people. Okay, GAT sphincter contraction. Alpha 1 decrease the intestine motility. So mean your sphincter are closed, mean your peristalsis go down. Okay, so they can cause a constipation problem. So kidney decrease the renal release. In the trigone, they cause the contraction, urinary retention. So as they contract, mean your urine cannot come out. So they are so you can give antagonist of alpha 1 for the BPA, benign prostate hypertrophy, where so you can use the alpha 1 antagonist to treat the BPH. Okay, and similarly, if someone has a bedwetting problem in the night time, so urinate, so you can use the alpha agonist because they cause the urinary retention. Vast difference, the contraction and emission. Remember, emission is associated with the sympathetic, while the erection, or you can say parasympathetic point, mean the erection is associated with the erection of penis associated with the parasympathetic, while the ejaculation is a somatic system. Liver, glycogenolysis and the gluconeogenesis, mean they increase the glucose level. So alpha 2 location, the presynaptic you know better, and the other location is the pancreas and the platelet. Presynaptic GI, of course, they decrease the cyclic AMP, so they decrease the transmitter release, norepinephrine release. Okay, so they are seen as sympathetolytic, while by the pancreas decrease the insulin by the beta cell. Platelet aggregation is also associated with the G2 function. So three function are with the G2. Now let's look at the beta receptor. So they are, all beta are the GS coupled. So beta 1 location is the number 1 is the heart, number 2 kidney, and the ciliary epithelium. Heart GS system increase the cyclic AMP, mean they increase the heart activity. By the SA node increase the heart rate, by the AV node increase the conduction velocity, by the myocardium increase the force of contraction. This is difference between the parasympathetic and the sympathetic. Parasympathetic has no effect on the myocardium, so they never decrease the force of contraction of the heart. Okay, while the sympathetic has three: SA node, AV node, myocardium. So increase in heart rate means positive chronotropy, increase in conduction velocity, positive dromotropy, increase in the force of contraction, positive inotropy. Okay, so in the kidney, they at the glomerulus, juxtaglomerular cell, they increase the renal release. Okay, so this is opposite with the alpha 1. Ciliary epithelium increase the aqueous humor production, so they can, if it's too much, they can cause the glaucoma. So and beta 2 location, blood vessel to the your skeletal muscle and cardiac muscle, especially skeletal muscle. So ciliary epithelium, uterus, bronchial smooth muscle, liver, pancreas, adipose. So and the mechanism you know better, GS. So you know what B2 is mostly not innervated, so you can say norepinephrine cannot play any role over the B2, so it is associated with the epinephrine. Okay, so they cause the vasodilation to the muscle, especially for example, you just think of the sympathetic condition. For example, you are running away from the dog, so you need more energy in your muscle to run away, so that's why we need the vasodilation to increase the blood supply to the skeletal muscle. So ciliary epithelium, same thing, increasing the aqueous humor production. So beta 1 as well as beta 2. In the uterus, of course, uterus relaxation, bronchial small muscle relaxation. So it's important, especially in the asthmatic, because they rely over this relaxation. In the if you inhibited this beta 2, what will happen in the asthmatic patient? They worsen the COPD condition or the asthma condition. So they cannot live without this relaxation. So this is important for the in the normal person. There's not a much problem if this relaxation doesn't happen. So but for the asthmatic one, it's necessary one. So beta 2 agonists induce the labor and the but if you give the treatment for the asthma, so you can give the beta 2 agonist. And the liver, they increase the glycogenolysis and gluconeogenesis. For this purpose, they increase the insulin. So this insulin actually not decreasing the glycogenolysis or glucose. This is actually because you are increasing the glucose level. So for the utilization of that glucose, some of insulin is released by the pancreas to utilize that glucose. So and other thing, by the adipose, which cause lipolysis, mostly associated with the beta 3. So beta 1, we have one heart and we have two lungs. Okay, so that's why most of us would love to memorize beta 1 heart and beta 2 lungs. So that's it's very important. So in the upcoming session, inshallah. So and the other is associated with the D1, the dopamine 1 receptor. So they are associated with the renal, mesentery, and coronary. So they increase the blood supply. So their mechanism GS simply. So they cause the vasodilation and increase the GFR and the RBF and the sodium secretion. Okay, so it's easier. So you try to memorize all these points. So because your whole pharmacology of autonomic rely over this table, adrenergic rely over this table, and the cholinergic on the last, which we have discussed regarding the location and the action of the receptor. So same summary we already discussed. So cholinergic and adrenergic. Okay. So just a summarizing point. So here is in the heart for the sympathetic beta 1, for the parasympathetic M2. So sympathetic increase the activity, parasympathetic decrease them. But you can see the myocyte are present in the sympathetic, but they are absent. The parasympathetic no action on the myocyte. Okay, cardiomyocyte. lungs, epinephrine is more effective as compared to the nerve. Because why? Because the lungs are associated with the beta 2, and the sympathetic beta 2 and parasympathetic M3, bronchodilation, bronchoconstriction. Okay, so kidney. So for the kidney, beta 1, for the kidney, the beta 1 and alpha. So beta 1 increase the renin, so stimulate the ROS system. Alpha arterial constriction, so they decrease the GFR. Overall effect, they increase the sodium and water retention. Okay, so but the parasympathetic no effect. So GAT sympathetic by the alpha 1, vasoconstriction by the they and the substitute constriction, so they decrease the mortality in the sympathetic condition, while in the parasympathetic this is vasodilation and sphincter relaxation by M3. GAT bladder normally be sympathetic B3 and alpha 1, and for the micturition M3 is going to control. So B3 tetrus relaxation, internal sphincter contract, so external sphincter contract, so you cannot urinate out. Okay, so these are contracted. So while in the parasympathetic M3 tetrus contract and your sphincter are going to open, so you can urinate. Okay, so the internal is by the M3, while the external is, just must remember this is with the external sphincter is somatic, so you can it is in your control. Okay, so I alpha 1, beta 1, beta 2 sympathetic para M3, alpha 1 mydriasis, the far vision accommodation, beta 1, beta 2 the ecostromal production. So and opposite is in the parasympathetic by the M3. Okay, so blood vessel vasoconstriction by the sympathetic and vasodilation by beta 2, vasodilation for the secondary cardiac. Okay, because they need energy in the your sympathetic condition. So vasodilation throughout by the parasympathetic by the M3. Second, alpha 1. Okay, only the sympathetic. So save the blood for vital organ, brain and heart. So second become cool to touch. Okay, so this store the blood for this purpose, because especially brain and heart. So paracetamol no effect. Salivary gland beta 2 M3, beta 2 thick saliva, so thick and viscous for the sympathetic, while the watery is for the parasympathetic. So in both conditions, your secretion in the sympathetic as well as in the parasympathetic is going to increase, but the difference is in the thickness. In the liver, alpha 1 beta 2 and parasympathetic M3 alpha 1 beta 2 glycogenolysis, gluconeogenesis increase the glucose level, while the parasympathetic decrease the glucose level. Okay, pancreas, alpha and beta 2 totally sympathetic. So alpha especially to decrease the insulin release, beta 2 increase the insulin release. So that's it. So just try to spend our time one on this table, and the last one the location and the function of receptor. So thank you very much. Allah Hafiz.